Hello and welcome everyone. Coming to today's session, when it comes to jaw swellings, there is so much that can be the cause. It covers the entire array of pathology, almost right from endocrines to infections to developmental to tumors, malignant and both and benign. So there's so much to do, and there's so much that we need to know which one it is, and it's always a little difficult. So the best thing that we have in hand to get over these problems is to have case discussions really and see the path as it's been cleared by those before us. So for that today we are very happy and very glad, and it's great that we have Dr. Jayanthi Varun. Dr. Varun is a practicing dental surgeon and an oral pathologist by profession. She is currently working as professor in the Department of Oral Pathology at Azeezia Dental College, Kollam. She is a fellow of the Indian Association of Oral and Maxillofacial Pathologists. We also have with us Dr. Karpagaselvi, also with us as the expert. She is the professor and head, Department of Oral and Maxillofacial Pathology, Vydehi Institute of Dental Sciences, Bangalore. And like she herself says, she loves taking part in slide discussions. So this is really up her alley. And she has a special interest in fibroosseous lesions and odontogenic tumors. So I welcome both of you. And with that, I'm just going to say, let's go on with the presentation.
A very good morning, all of you. Today, I'm going to give you a short discussion, which is a case-based discussion on jaw swellings. As Dr. Mandana already mentioned, we have a wide range of jaw swellings, ranging from a simple reactive lesion to an inflammatory, going up to a neoplastic lesion. Now, whatever I'm going to discuss today, be it the concepts or the cases, some of it might be very basic. I'm intending that for the beginners and the postgraduates. To start with, jaw bones are unique when compared to other bones of the body because embryologically they are derived from the neuroectoderm, whereas the other bones are actually derived from the mesoderm. And anatomically also they are unique because they are housing the two germs within them. And because of this simple reason, whenever we have a swelling of the jaw bones, primarily they belong to odontogenic origin, be it either odontogenic cyst or tumors. But we also should keep in our mind that we have a group of non-odontogenic lesions which may be reactive, inflammatory, or neoplastic. So to just simply classify the odontogenic and the jaw lesions or jaw swellings, as I already said, because we have two germs within the jaw bones, we always have to consider the odontogenic lesions before considering anything else in the differential diagnosis. So we have odontogenic tumors in one end, which can be either benign or malignant tumor, and each of these category can arise either from the odontogenic epithelium or from the ectomesenchyme, and we have a third group which have components of both epithelium and ectomesenchyme. On the other hand, we have odontogenic cysts, which can be either developmental or inflammatory in nature. In between, we also have a group of tumors which can primarily occur within the bone, which may be either benign or malignant. We also have metastatic tumors that commonly occur in the bones, and we have hematolymphoid tumors, including lymphomas and solitary plasmacytomas. Other than that, we should not forget about the most common inflammatory bone diseases, including osteomyelitis, reactive bone diseases, fibroosseous lesions, giant cell lesions, and other pseudocysts like traumatic bone cyst and aneurysmal bone cyst. So with this basics in mind, let us quickly move on to our cases. So the first patient was a 32-year-old female patient. She complained of a swelling in the lower anterior region, that is in the midline of the chin, for the past 6 months. On extraoral examination, the lymph nodes were not palpable. She had a diffuse swelling in the chin area, and intraorally, when we examined her, there was a diffuse swelling again extending from the canine region of one side, that is the 3-3 area, to the 4-3 area, crossing the midline. This diffuse swelling was non-tender on palpation and it was obliterating the labial vestibule. And this was present in a 32-year-old female patient. So we went ahead and took an orthopantomogram, and you can see in the picture that there was a well-defined unilocular radiolucent lesion that was extending from premolar of one region, that is 3 4, and going to the mesial root of 4 6. So it was such a big lesion, whereas clinically we had only a very diffuse swelling involving the anterior two. But in radiographically, I can see the full extent of the lesion extending from premolar of one side to molar of the other side, and it was almost coming close to the lower border of the mandible too. Now, based on all these clinical and radiographic features, a clinical differential diagnosis that were considered were central giant cell granuloma, glandular odontogenic cyst, and of course ameloblastoma. Now, at this point, I wanted to make one comment here. Whenever you have a swelling in the anterior region of mandible, if it is crossing the midline, this is for the postgraduates and the beginners, you should all, and if that patient is a young adult patient, always consider central giant cell granuloma, because that is a very common location for a central giant cell granuloma to occur. And among all the odontogenic cysts, glandular odontogenic cysts, around 75% of them are supposed to occur in the midline of the mandible. That is very, very common site for glandular odontogenic cysts. That is why I have put these two lesions in the differential diagnosis. Naturally, you can also think about periapical cementosseous dysplasia. But again, in periapical cementosseous dysplasia, most of the times you get a mixed radiolucency radioopacity most of the times. And also, it will be restricted to the periapical region of the incisors. So that's why I have not considered that in this differential diagnosis. We also have some ameloblastomas occurring in the midline of the mandible, although the common location for a conventional ameloblastoma is posterior region of the mandible. Now, next thing what we did was, we did an aspiration of the lesion. We knew that there was an involvement of the bone. So we went ahead and did an aspiration of the lesion, and we got a clear low viscous fluid by aspiration. So keeping all this clinical radiographic picture, and also because we received a clear fluid on aspiration, the surgeons narrowed down the diagnosis to a cyst, and they went ahead and did a enucleation of the lesion. So this is the surgical picture. The lesion was completely enucleated and removed. And what did we have in the histopathology? On microscopic examination, under low power, you can see from the picture here, there was a clear cystic lining that was noted. And in this picture, what I want every one of you to appreciate is, in some areas, there are nodular thickenings of the lining. So that is one thing we need to appreciate here. And in the next high power, we can see that it is a uniform, most of the areas, it is a uniform lining. It is a non-keratinizing stratified squamous epithelium. And many areas within the epithelium, we are able to appreciate clear cells or mucus cells within them. And there were also microcystic spaces within the epithelium. You can see again the non-keratinized stratified squamous epithelium, and you see microcystic spaces within the epithelium. And on the surface of this epithelium, a classic hobnail cells were seen. They are nothing but cuboidal cells with the eosinophilic cytoplasm, which is seen on the surface of this epithelium. And as I mentioned in the first picture itself, there are some areas where there were nodular thickenings or sperules or whorls of cells within the epithelium. So all this, they are nothing but cuboidal cells with the eosinophilic cytoplasm. All this is pointing towards a final diagnosis of glandular odontogenic cyst. And everyone is aware of the diagnostic histopathological criteria given by Kaplan et al. For glandular odontogenic cyst. We have 5 major criteria. All these 5 major criteria has to be present in a particular case to call it glandular odontogenic cyst. We have 4 minor criteria. These are not mandatory, but it only adds an additional point for diagnosis. So in our particular case, all these 5 major criteria were present. That is non-keratinized squamous epithelial lining with the flat epithelial connective tissue interface. We had epithelial whorls or spirules, presence of hobnail cells, presence of mucus cells, and also presence of intraepithelial microcyst formation. In addition to all these 5 points, the additional point present in our case was presence of clear cells. So this is a post-operative picture. The patient was followed up for 6 months, and after 6 months, the healing was good. And this is the clinical picture of the post-operative healing. Here, the point I wanted to make specifically tell is, compared to all the odontogenic cysts, glandular odontogenic cyst is one type of cyst which is supposed to have an aggressive nature. It can spread very rapidly to the surrounding structures, and it can destroy bone very faster than the other odontogenic cysts. And because of this reason, if you do a typical enucleation only, that results in a higher recurrence rate. But considering the age of the patient, because this person was a young adult, we went ahead and did only a simple enucleation. However, the healing is good for 6 months, and we need to follow up patient for a longer duration for a better. So the lessons that we have learned from this particular case is that aspiration is mandatory for all intra-bony radiolucency before we proceed with biopsy or surgery. Now, why this is very, very important is because you should also keep in mind that we can have intra-bony vascular malformations, or we can have intra-bony hemangiomas, which can also present as radiolucencies within the mandible. So if we are not going to do aspiration and directly proceed with the biopsy or surgical treatment, then we will end up in trouble. Patient will have bleeding and hemorrhage, which you are not prepared for, and you will be landing up in trouble. Therefore, always remember, whenever you have an intra-bony pathosis, which is a radiolucency and a destructive lesion, keep in mind that aspiration is really needed before you go ahead and do a biopsy. Second thing is, we have a major set of diagnostic criteria to call it glandular odontogenic cyst. You might not be able to see all these features in one area or one shot. So careful evaluation of multiple sections and multiple areas are necessary to come to the diagnosis of glandular odontogenic cyst, because there are some features which are overlapping with low-grade intraosseous mucoepidermoid carcinoma, especially the microcyst formation, cystic areas, then mucus cells, clear cells. All these are seen even in a low-grade mucoepidermoid carcinoma. So you have to keep in mind this one, and then multiple sections have to be evaluated, and finally the diagnosis of glandular odontogenic cyst have to be made. So moving on to the second case, again it was a young female patient who was 25 years old. She had a swelling on the right side lower part of the jaw since 2 months, and it started as a very small swelling and gradually rapidly increased to the present size. Now this is the clinical picture of the patient. She had a diffuse swelling in the right side lower part of the jaw in the mandible. It was a ill-defined swelling. The borders were not very clear. It was a non-tender, painless swelling, but it rapidly increased. Within a matter of 1 or 2 months, it increased to a large size. And on intraoral examination, we noticed that this swelling is extending from the canine region, that is 4-3 region, going up to the molar area. The buccal cortical plate was expanded. The buccal vestibule was obliterated. It was a bony hard swelling, and it was non-tender on palpation. A CBCT image was taken. I'm very sorry about the quality of the picture. There was a ill-defined radiolucent lesion involving the premolar and the molar region, indicating a destruction happening within the bone. So you have a young female there with a diffuse swelling in the mandible, where there was a radiolucency in the radiograph. So the common differential diagnosis, as I already told, always have odontogenic lesions. Give them priority whenever you have a swelling in the teeth-related areas. So we had ameloblastoma and odontogenic keratocyst as our differential diagnosis. So we went ahead and did an incisional biopsy, and on microscopic examination, we observed multiple islands and nests of cells. They were all neoplastic cells. They were proliferating. All these nests were separated by a fibrous septa or connective tissue stroma. Now, when we go to the higher picture, we can clearly appreciate that each of this island is made up of two populations of cells. One group of cells have a clear cytoplasm with a very prominent hypochromatic nuclei. The second group of cells, they were squamoid in appearance, that is, they were basically polygonal in shape, with a moderate amount of eosinophilic cytoplasm and a hyperchromatic nuclei. But all these cells were uniform in appearance. They did not show any pleomorphic or dysplastic features. And now we know that there are so many lesions which can show clear cells. Though we considered odontogenic keratocyst and amyloblastoma in our clinical differential diagnosis, the histopathological features do not have anything relating to amyloblastoma, neither odontogenic keratosis. We have islands and follicles of cells with two populations of cells and one group being clear cells. So whenever we have clear cells, again we have to think about salivary gland tumors. Of course, they are unusual to occur within the jaw bones, but still, because of clear cells, we have to think about salivary gland tumors. And you also have some odontogenic lesions, tumors, which can have clear cells. Specifically, you have clear cell variant of pinbox tumor, and you also have one group of tumor called clear cell odontogenic carcinoma. So, to know that whether these tumor cells are either salivary gland origin, whether they contain mucin or they are not odontogenic in origin, we did some special stains and immunohistochemical markers. The special stains that we did were mucicarmin. All these cells were negative for mucicarmin staining, whereas when we did a periodic acid shift staining, all these cells, including the clear cells specifically, had taken up PAS stain and they appeared magenta in color, which you can see from the picture here. So now we know that because they were negative for mucicarmin, the clear cells do not have mucin within them, so they are not mucus cells, but they are PAS, they contain a PAS positive material. So the next investigation that we did was we did immunohistochemistry. We did pancytokeratin. All the tumor cells were positive for pancytokeratin. And we did a CK19 marker, which is specific for ontogenic epithelium. And the tumor cells were also positive for CK19. And this is telling us that they are of ontogenic origin. So among the ontogenic tumors, we had two group of tumors in mind. We have either clear cell variant of pinbox tumor or clear cell ontogenic carcinoma, but we clearly think about the immunohistochemical marker, not only that, but we also have the microscopic features here, the two biphasic population of cells arranged in islands and follicles with a septum, fibrous connective tissue septum. All these are pointing towards the diagnosis of clear cell odontogenic carcinoma. Now, it does not end here, because the patient, after incisional biopsy, the diagnosis of clear cell odontogenic carcinoma was made. But the patient was a young adult who was getting married in 1 month. Her marriage was fixed for the next month. So even though I told her that this is a malignant tumor and this needs to be treated immediately, looked into it immediately, she was not willing to do so. She said she didn't even want to tell about this to her husband, future husband, and she went ahead and she refused any further treatment, and then she went ahead and got married, and we lost her for follow-up. After 3 months, she came back to us like this. And I think you all can appreciate how big the swelling has become now. It is very obvious. The first time when she came, it was not this obvious. But unfortunately, now within a matter of 3 months, the lesion rapidly enlarged in size, involving considerable portion of the mandible, a large swelling causing facial deformity. And she came back again to me telling that now something has to be done. So we already know the diagnosis, clear cell odontogenic carcinoma. So we did a CT scan again to know the extent of the lesion now, because it is grown in size and it was involving the entire right side of the mandible. It extended up to the midline of the mandible and up to the posterior ramus region of the mandible. So it was spreading very fast and it is an aggressive tumor. So we planned for complete resection of the mandible. So because she's a young patient, reconstruction was also planned along with that. So a 3D print of the mandible was made with the help of the computer, and then complete resection was done, followed by reconstruction. And this is her post-surgical radiograph following 1 month after the surgery. The resection of mandible and plating and reconstruction was done for this patient. So what are the lessons that we have learned from this particular case? We all know that few years back in the older WHO classification, this particular lesion was called clear cell odontogenic tumor. It was not even called carcinoma, because they thought it was, though it was a malignant tumor, It was less aggressive, did not have any metastatic potential. But now we have a lot of reported and reviewed cases from the literature. And what we know about this particular lesion is that it is an aggressive malignant tumor. It spreads very rapidly, it destroys bone very rapidly, it causes destruction of the surrounding and the underlying structures. It also have a tendency for local recurrence as well as for distant metastasis. So aggressive treatment or wide surgical resection has to be done for these patients. And the other thing that we have to keep in mind is there are some times where we have to rely on special stains and immunohistochemical markers, which will aid us to come to a final and confirmatory diagnosis. Because in this particular case, we relied on CD19 to confirm that these cells are odontogenic in origin. Now, moving on to the next case, that is the third case. So, all the patients we have today are young females. So, this is also a 25-year-old female patient. She had a swelling on the left side of the face for the past 1 month. And the history is that she had an orthodontic treatment 2 years back. Once her orthodontic treatment was over, she noticed a small mobility and swelling in the area of the upper anterior region. So she visited a local dentist and they had taken a intraoral radiograph, and they said that the teeth were mobile because due to an orthodontic treatment, the teeth have become non-vital and she had periapical infection of that particular teeth, and so root canal treatment has to be done. This was the advice given by a local dentist. The problem here is only an intraoral periapical radiograph was taken and all the diagnosis was made based on the intraoral periapical radiograph. However, this particular patient is a nurse by profession. So she wanted to take a second opinion and then she came to me. And this is how her extraoral appearance was. I noticed a diffuse swelling on the left side of the face. The swelling was obliterating a nasolabial fold. And on intraoral examination, you had a diffuse swelling in the upper anterior region extending from 2-1 area to 2-3 area. All these three teeth had grade 3 mobility and the labial vestibule was obliterated. It was a non-tender swelling. Then I went ahead and took a OPG, orthopantomogram, and I noticed that the bone was totally lost there. All these teeth were floating in air. There was not even a bone support for any of the tooth there. Complete bone destruction had happened, extending from 2-1 region to 2-4 region. All the three teeth had grade 3 mobility and they were all floating. So there was a total destruction. An occlusal radiograph was also taken and you can see the extent of the lesion, a radiolucency and bone destruction extending from the incisor area up to the second premolar and molar area. So to know the exact extent of the lesion and plan for her treatment, we had also taken a CT, and CT shows again an expansile lesion. The buccal cortical plate is having an expansion and there is bone destruction involving the anterior region of the maxilla. So now we have a young patient who had an orthodontic treatment. Now she has mobility of teeth and bone destruction involving her upper part of the maxilla. Of course, all the teeth are non-vital. So we definitely have to consider, though the destruction looks very bad, still we need to consider periapical cyst in the differential diagnosis, because by books, the teeth are non-vital and there is radiolucency associated with the teeth. We also have to think about adenomatoid odontogenic tumor because of the location, and she's a young female. We can rarely get ameloblastoma involving the anterior portion of the maxilla. Though all this are considered, I was more convinced towards a malignant neoplasm because there was grade 3 mobility and rapid destruction of bone in that area. So we opened up to take a biopsy, and I put this picture specifically to show you that when a flap was reflected, I could not see the buccal cortical plate at all. The bone is totally lost there. When the flap was reflected, I could see the roots of the incisor tooth there. So there is complete destruction of the buccal cortical plate. So that is very, very important that we have to note here during the surgical procedure. So maximum how much ever lesion was able to be removed by surgical procedure. All that tissue was removed and it was subjected to histopathological examination. And what you can see here in the picture in the low power is that there were lobules of cartilage. Lobules of cartilage, all this pale staining area here. I'll show you the high power view shortly. We could see lobules of cartilage, and all these cartilage were not normal cartilage, but they were abnormal. They had pleomorphic cells. The size and shape of the cells were abnormal and different. The size and shape of the nuclei were abnormal, and you could see sheets and lobules of this cartilage. In fact, most of the sections, whatever was taken, removed surgically from the patient, extensive areas of cartilage were seen. And this is a higher power view of the cartilage. You can see the pleomorphism is very well appreciated in this picture. So you can clearly say that it is not a normal cartilage, but it is a malignant or an abnormal cartilage. So at one glance, most of the area showing malignant cartilage and rapid destruction of bone in a young female, anterior maxilla. So I was thinking more towards a chondrosarcoma. But however, I kept in my mind 2 points. Number one is usually the gnathic chondrosarcomas or chondrosarcomas in general are very unusual in younger patients. They most commonly occur in older adults of above 50 years. You cannot say that it will never occur in younger patients, but they are very uncommon in younger patients. That is one thing. And second thing I kept in mind is that compared to an osteosarcoma, chondrosarcomas are unusual in jaw bones. So I went ahead and took multiple serial sections, and I took deeper sections of the same tissue, and in one area, only in one area, I could see proliferating mesenchymal malignant cells here, and some Jan cells also were seen in that area. And in one corner of that tissue, I could see appreciate tumor osteoid. The arrow pointing out here, two areas, only in one foci I could see that you can have tumor osteoid in that one foci. Otherwise, completely sheets and lobules of cartilage only were seen. Only in one foci I could appreciate the tumor osteoid. Now the entire diagnosis has changed because of the presence of tumor osteoid, though it is only in one foci, whereas the malignant cartilage is seen predominantly in sheets and lobules, but still this lesion, the apt diagnosis would be to call it chondroblastic osteosarcoma. So that is what the diagnostic criteria says us. Even though you see sheets and majority areas are filled with malignant cartilage, even if one focus or one area, if you are able to appreciate and see a tumor osteoid, you should definitely call it a chondroblastic osteosarcoma, not a chondrosarcoma. So because already that patient surgical excision was done and most of the tissue was removed during the biopsy procedure itself, and now the diagnosis is confirmed as osteosarcoma, we referred her to regional cancer center where the diagnosis was reconfirmed, and then she was given post-surgical chemotherapy. After chemotherapy, we had 1 year post-operatively. She came back to us, and this is the radiograph taken 1 year after a chemotherapy treatment was completed, and you can see the healing is good. There is no recurrence. Patient was doing apparently well. So, what are the highlights and the important points that this case is telling us is the importance of serial and deep sections before we come to a final diagnosis. If I had not taken that multiple serial sections or deeper sections and not carefully noticed all part of the tissue sections properly, maybe I would have given a diagnosis of chondrosarcoma. So, what is the problem? Why can't we, whether we call it chondrosarcoma or osteosarcoma, is there really a problem? Because both are malignant tumors of bone. So, why not just call it chondrosarcoma? No. Why it is important is because the treatment management of the patient and prognosis is going to differ considerably in both these cases. From the literature and studies, we know that for a osteosarcoma, only surgical excision is not enough. You have to give post-surgical chemotherapy. Patients who have received post-surgical chemotherapy respond very well, and their 5-year survival rate is also improved. Recurrence rate is minimal. So, whereas for chondrosarcoma, only surgical management is more than enough. When we come to prognosis part, Compared to both this lesion, chondrosarcoma has a better prognosis. So that is why it is very important for us to know whether it is osteosarcoma or chondrosarcoma. So we will move on to the last final case, that is your fourth case. Now this patient is again a young patient in a middle age. She is around 37 years old, and this patient came to us with a swelling on the right side of the mandible. And clinically, when I examined her, on the right side mandible, posterior region, there was expansion of the buccal cortical plate and the alveolar ridges were enlarged. All her teeth were migrated and rotated because of this swelling. She had severe pain in that area, not only swelling, but she also complained of pain in that area. Whereas extraoral examination, there was no lymph nodes that were palpable both on the right side and the left side. Only intraoral findings were noted. So CBCT was taken for this patient, and the typical appearance that we saw was a moth-eaten appearance. That is basically multiple areas of radiolucent destruction of bone was noted in the mandible. You can see in the lowermost part of the picture more on the molar and in this edentulous area, little bit even extending into the anterior area, but on the right side of the mandible, there was complete destruction of bone. So this is again another imaging picture that we have here. The arrow that is pointing out here is that on the buccal aspect of 4-7 region, I want every one of you to notice that there is a mild periosteal elevation. So this is what classically we call the Codman's triangle. If you see in the textbooks, something is mentioned as Codman's triangle. That is nothing but tent-shaped elevation of the periosteum, creating a triangular shaped area, which was first described by Codman. That's called as Codman's triangle. That was noticed in the radiograph of this particular patient, where in the buccal aspect of 4-7 region, this Codman's triangle was noted. And another important feature that we noticed here is all the teeth, mandibular teeth, had widening of the periodontal ligament space. Not one or two teeth, but almost all the teeth. There was generalized widening of the periodontal ligament space. So because of the presence of this Codman's triangle and also extensive bone destruction, diffuse moth-eaten appearance, and rapid enlargement of the swelling, all this, the differential diagnosis that was given by the radiologist as well as by the clinician, we need to consider definitely malignant tumor. So we considered osteosarcoma, but we should also keep in mind that there are some metastatic tumors which can metastasize to the jaw bones and can cause a diffuse area of radiolucency and moth-eaten appearance in the radiograph. So these were the two differential diagnoses that we considered for this case. We went ahead and did an incisional biopsy from the molar region, and on microscopic examination, we saw sheets of round blue cells. Sheets of round blue cells, very minimal connective tissue stroma, just a thin fibrous stroma was seen in between these cells. The high power view of this tumor cells, you can appreciate that the cells are almost round or ovoid in shape. The cytoplasm is very minimal. Prominent nucleus is present. Most of the tumor cells had a vesicular nuclei. Some of them, very few, had hyperchromatic nuclei. But you can appreciate that they're almost uniform in size and shape. Although they are round blue cells, they are uniform in size and shape. You don't appreciate much of pleomorphic features in these cells. In between, the fibrous stroma is very, very minimal, thin fibrous stroma. And you also see areas of vascularity in this connective tissue stroma. So you have a rapid destruction of bone in a 35-year-old female patient, giving a moth-eaten appearance in the radiograph. On histopathological examination, we have sheets of proliferating neoplastic cells. They are round blue cells. So now all of you know what are the round blue cells commonly producing swelling in the jaw. So we need to definitely think about Ewing sarcoma, a primitive neuroectodermal tumor, that category. We also have to think of lymphoid proliferation, that is hematolymphoid tumors that can also have this kind of histopathological appearance. So considering all that, you also have sometimes undifferentiated carcinomas which can have such kind of appearance. So keeping all that in mind, we went ahead and did a panel of immunohistochemical markers where we did pancytokeratin, we did CD99, and we did CD45. Pancytokeratin and CD99 were negative, whereas the tumor cells were positive for CD45. That is common leukocyte antigen. LCA was positive. So with this, we know that they are all lymphocytes. The proliferating neoplastic cells are lymphocytic in origin. So next thing we want to know whether they are T lymphocytes or B lymphocytes. So CD3 was done for a T cell marker and CD20 was done for a B cell marker. As you can see from the picture here, the tumor cells were negative for CD3 whereas they were positive for CD20, confirming that they are of B cell origin. So the diagnosis is a B cell lymphoma. But we should keep in mind that in a healthy young female patient, to get a primary lymphoma of the jawbone is not very common. So we wanted to know if she is having lesion anywhere else in other parts of the body. So chest radiograph was taken, ultrasound abdomen was done. A physician had done a complete systemic examination. Apparently, she did not have any other abnormalities anywhere else in the body. And we also did a HIV test for her to check if she had immunosuppression. Her HIV status was also negative. So based on all these features, final diagnosis was made as primary B cell lymphoma of the oral cavity. Of course, further subtyping has to be done. We have different types of non-Hodgkin's B cell lymphoma. So many different varieties are there. So you have to subtype it because the prognosis and the treatment options, the type of chemotherapeutic drugs given for each type of lymphoma is different. The prognosis is also different for each type of lymphoma. So subtyping has to be done, but the final diagnosis is confirmed as a primary B cell lymphoma of the oral cavity. So this is the final diagnosis for case 4. So now today we have discussed totally 4 cases, all of them occurring in a young female patient ranging between 20 to 30 years of age. There were 3 cases which produces swelling in the mandible, with 1 case in the maxilla. So what are the take home messages that we are going to keep in our mind at the end of this discussion is that, as I already mentioned in the beginning itself, we have a wide range of lesions that can cause swelling in the jawbones. It can be reactive ones, it can be inflammatory ones, or it can be a neoplastic ones. But we have to consider everything in the differential diagnosis, but always consider the odontogenic lesions because jaw bones are housing the tooth germs. Have to consider odontogenic lesions primarily, rule them out, and then go for the non-odontogenic lesions. Correlating the clinical and radiographic findings with the histopathological feature is a must. I re-emphasize that point. Everyone knows that, but I still want to re-emphasize that because that is very, very important to come to a final diagnosis. Aspiration of all intrabony radiolucent lesions are must and mandatory before we proceed with any biopsy or surgical procedures. Multiple serial sections and deeper sections are very, very important before we come to a diagnosis, especially if you're looking for an incisional biopsy specimen. And in many of the cases, or in at least a few cases, IHC markers, immunohistochemistry, and special stains will help us to come to a final confirmatory diagnosis. So we have come to the end of this discussion. I have not included inflammatory and reactive lesions because we have a very limited time. It is not possible for me to cover the entire things. That is why I've concentrated more on neoplastic lesions, which included both odontogenic and non-odontogenic neoplasms. Uh, if any of these points or basic things I've told you feel is quite basic, please excuse me because I wanted to primarily emphasize this case-based discussion for the beginners and the postgraduates. Mm, I really thank Dr. Mandana for giving me this opportunity. I've been a big fan of this program, Oral Pathology Tuesdays, and I'm really happy and glad and proud to be part of a speaker and part of this program today. And I also really thank Dr. Karpagaselvi for accepting the invitation and being an expert and moderator for this session. And finally, I would like to thank all the listeners for your patient listening. Thank you so much, all of you.
Thank you, Dr. Varun. That was indeed a great presentation. And you are most welcome. And I'm so glad you like this channel and you follow it. That is what it's all about. So now for our audience, please put in your questions, your comments, and of course, if you love the presentation, don't forget to hit the like. And while because there's a lag, while you go on and add in some questions there, I would also like to share a little news with you. Some of you may remember last year we had an oral pathology international case presentation webinar that was in Feb with a number of international and national dental schools and organizations that were helping out as academic partners. So we have all come to part two now, the second year. And second year is going to be bigger and better, of course, because everything has to improve with time. Otherwise, there's just no point. So in this year we have and yes, you can see that is the logo of the International Association of Oral Pathology, who is also one of the academic or knowledge partners. And then we are continuing with Asian Society of Oral and Maxillofacial Pathology, a number of institutions from around the world. And please note, there is no particular reason with the arrangement. It is more for aesthetics and how the logos fitted together, because that's quite a job putting them all in there together. Anyway, this is early information. By next week, we will share with you how to register for the event. And what you will need to do is, if you want to present cases, please find your cases. So start looking and then get ready for the preparations. We will put in the registration date and the abstract submission date. And it is really going to be much better. We are going to have use a platform that actually allows proper interaction. You will have a reception area, you will have networking area, you will have an ability to watch the programs for 15 days after the whole event is over. We will have 3 live sessions, which will be the case discussions. It will be arranged in such a way that people from anywhere in the world will be able to attend and present at least in one live session. And of course, then there is going to be a lot of recorded events and recorded discussions that anyone can watch anytime. It will be effectively a 2-day event. And well, we are looking forward. As you can see, we have a really big collection of institutions that are going to help. And I hope you will all really enjoy it and you will join us. Now, with that, let's get on with the discussion. Yes. So let me go here. And right. Here we are. Okay. So I think there are already some questions. I will bring the first one on. And right. So Dr. Joss is saying, did you consider submitting the odontogenic clear cell carcinoma for EWSR1 gene rearrangement?
No, we haven't done that, but I had taken a look at that paper where they have made a cell line, EWS ART cell line out of the clear cell ontogenic carcinoma, and they say that this research will help us to maintain a cell line for all the malignant ontogenic tumors. I went across that article just few days back. But our particular case, we haven't considered that. We haven't done that. Maybe probably in future we will try to do it.
I would like to come here. That was a very good presentation, Dr. Jayanthi. You
Thank you.
have covered you have covered all the neoplastic, uncommon, not so common lesions. And particularly, I would like to mention in case of clear cell odontogenic carcinoma, Dr. Jose mentioned about EWSR when gene rearrangement to be done. But if you see the literature and if you see WHO, they have come out with a statement that 80% of cases of clear cell odontogenic carcinoma show EWSR1 gene rearrangement. And at the same time, they have also mentioned that there is one more lesion, that is clear cell carcinoma of minor salivary glands, which occurs in the oral cavity. They say some of them also show this gene rearrangement. So whether EWSR1 will really help you when you are considering the location, say like a lesion on the palate, whether this gene rearrangement will help, I am not sure. I'm not so sure. But
Yes, ma'am. Because many of this, as you said, they are mentioning that many of the hyalinizing clear cell carcinomas of the salivary gland also shows
yes,
up this EWS fusion gene. So, because as you said, it is all in the initial preliminary research stage. We have not come to a level where it is mandatory for us to check for EWS to come to a diagnosis. I think we need to have furthermore studies on this to get a clarity, like you said.
and I think what really helped you in your diagnosis out here was your histopathology, the location of the lesion, the biphasic nature of your lesion. But then, if you look out into the literature, you said it is CK19 positive. So CK19 positive, you wanted to rule out only clear cell variant of Pinberg's tumor. But if you see the recent literature, especially the one which has come out from Sri Lanka and with lots of other authors, there is something mentioned. There is two types of clear cell variants of CEOT or Pinberg's tumor. One is the calcified variant, and other is non-calcified variant. So, calcified variant, you will be seeing the classical features, that is your calcifications or lysigangring somewhere in the section when you are doing multiple section. But there's something called as non-calcified COT, which you have to rule out, especially if you are seeing hyalinized areas. And I feel the simplest way, though it is mentioned in literature that EWSR1 rearrangement is not seen in clear cell variant of COT, what I would suggest is in such cases, you can just rule out COT non calcified variant where you are not seeing lysigangry by doing Congo red stain. And after doing the Congo red stain, you just subject the section to polarizing microscopy. So if at all it is non-variant, you will be non-calcified variant, you will be seeing your apple green
By
by
reference.
so that will help you. So I think that could have been done maybe, just since we are talking about PG postgraduates. Yes, this can be done to further
Differentiate these two lesions.
emphasis your diagnosis. That I feel. And next thing also I would like to mention is somewhere in the literature there are three variants which are mentioned for clear cell odontogenic carcinoma. So the one variant which you have described is the biphasic one,
Basic variant.
and there is something called as monophasic. So monophasic is the one which causes really difficulty in diagnosis,
Diagnosis. Exactly.
and the third one is your amyloblastomatous variant. Yeah.
But in
So,
some areas, you should be seeing a typical amyloblastomatous follicle to call it amyloblastic variant. So
but
that also the diagnosis is not difficult. Like you said, the monophasic variant is the one we'll be having trouble with. But
in,
unfortunately, because this case had biphasic variant, it was easier for us to come to the diagnosis.
but I was while going through your slides, while looking at your musicamine stain, I felt it is showing somewhat amyloblastomatous pattern. You know, it is showing the tall columnar cell. The slide which you have used for musicamine, it is showing somewhat the tall columnar cells at the periphery, and in center it is showing stellate reticulum, and also I can see cystic degeneration. So I thought of telling you about that also. Yeah. Otherwise, it is a good case. Any other questions are there?
Yeah, there is another one again from Professor Hilly. Yeah. So, if one struggles to find malignant osteoid formation, one can try to apply SAT-P2 immunohistochemistry indicating bone generation, but this stain must be appreciated in the right context. Okay, so it's just an additional information.
Comment, yeah.
Yes.
Okay. So I don't think there is anything on that case. And
So, Dr. Jayanthi, I would also like to ask you, have you thought whether any, since we are talking most in from the point of postgraduates, do you think there is any IHC marker which might help us to differentiate chondrosarcoma from chondroblastic variant of osteosarcoma?
Even in the same case which I had mentioned, ma'am, actually we had discussed with the Cancer Institute people, and we had a lot of discussion regarding this case. Like, how do we really come to a diagnosis? Then actually they suggested to do S100.
Yeah.
Actually they said that it has worked very well for them whenever they had a trouble, because I'm frankly telling you this, because we had a extensive discussion with the pathology head and their team in this patient, because I was personally involved with this girl. I felt really sorry for her. She was so young and she's also a nurse by profession, so I took personal interest and we went for a discussion with the RCC team in Trivandrum. And finally, what they did was they did S100, ma'am. With the help of S100, only they convinced us and themselves that it is chondroblastic osteosarcoma. So,
Okay.
what is your opinion on this, ma'am?
Actually, I'm not sure about S100 because when I look upon the literature, both chondrosarcoma and chondroblastic variant of osteosarcoma, both are showing positivity for S100. But if, in fact, if something which is negative in chondrosarcoma, that is actually epithelial membrane antigen. They are
Yeah,
saying that that is negative in chondrosarcoma and it is positive in osteosarcoma.
osteosarcoma.
Yeah, I have never used the IHC markers, though we have got the case of chondrosarcoma. And like you mentioned, it is seen more in elderly female. Our case of chondrosarcoma was in a pediatric population. So we had two cases, one in 9-year-old child and one maybe around 14-year-old child.
But again, there is that mesenchymal chondrosarcoma. They say that it can occur in pediatric population. What about your case, ma'am? Was it in
No, ours was pure chondrosarcoma. In fact,
conventional chondrosarcoma?
conventional low grade, grade
Chondro.
one chondrosarcoma, and yeah, and it had the typical location of anterior portion of the maxilla. Yeah,
Yes.
anterior portion of the maxilla.
But still, that age group, they say that less than 20 itself is very, very unusual and rare for chondrosarcomas to occur in
I
the
think
body.
if you look up the literature, I think very few studies are there. Just 20 cases or something have been discussed, you know. So yes, definitely it's less. Yeah. So any lab investigations was done for this case of chondroblastic osteosarcoma? Any blood investigations? I
Uh,
just
no, ma'am. Before the surgical treatment, anyways, the routine, all the tests were performed.
okay.
Basic, all the blood investigations were performed. Otherwise, specifically, we did not look into any other. Like, are you asking something related to parathyroid hormones or calcium
Or
levels?
maybe alkaline phosphatase, yes.
Yes,
And,
yes. So alkaline phosphatase. So because it was a bone lesion, along with this routine hematological investigation, serum calcium and vitamin D and serum calcium, vitamin D, parathyroid hormone, and alkaline phosphatase were done, ma'am. All these were all within normal limits.
okay.
Right. So our last question, again from Professor Joss. So, did you consider Burkitt lymphoma, and one could do ISH for EBV, EBER? This can be done following IHC methodology.
Yes, Burkitt's lymphoma, we all know it's called reason is Epstein-Barr virus, and it is called jaw lymphoma because that is one lymphoma which commonly occurs in the jaw, but it is also predominantly a lymphoma of children. Almost around 80 to 90% of the Burkitt lymphomas occur in children, and it has a characteristic histopathological appearance, what we call the, for postgraduate starry sky appearance. We have two population of cells. Though the neoplastic cells are round blue cells, in between them we also see this pale staining macrophages in between them. That's very characteristic of a Burkitt's lymphoma. And of course, we also have translocation. We have not done any translocation studies in our particular study, but still, Burkitt's lymphoma shows translocation for chromosome 14 and 18. So all these are there. We did not have this classic starry sky appearance. It was just uniform round blue cells. And our primary diagnosis was aimed to just know whether it is lymphoma or not. And if it is a lymphoma, if it is B cell or T cell lymphoma. And I mentioned at the end itself that further subtyping needs to be done, whether it is a diffuse large B cell lymphoma or a follicular lymphoma, whatever it is, a further subtyping needs to be done. That will be done, and accordingly, the patient will be managed.
So, okay, that was our last question. No, one second, there is more. Right. Dr. Rebecca is asking, can you elaborate on the significance of aspirates in any of these lesions?
Actually, I would like to say my own experience. This was not now, anytime now, maybe around 25 years back when I was doing my undergraduation. I had visited one of the government hospitals just for a training purpose. And the doctor there was planning to do a biopsy for a person who had a radiolucent lesion in the posterior region. It was a multilocular radiolucency. So the provisional diagnosis was amyloblastoma. So the surgeon, you just have to imagine it's a simple primary healthcare center. So the doctor was a surgeon, he was a trained personnel. The moment he opened up, made an incision and reflected the flap, you cannot imagine the mouth was completely filled with blood. How much ever we are trying to control the bleeding, we were struggling for 1 hour completely. We had to call up for backup. We had to do his blood typing, immediately arrange, because the patient arranged for blood, the patient was going in for shock. The point I'm trying to make here was that was actually a intraosseous vascular malformation. Unless and until we are seeing it histopathologically and telling what is the final diagnosis, whatever diagnosis we are making based on the clinical or radiographic features are only provisional. We can never confirm the diagnosis without a histopathological examination. So for that, even to do a biopsy, you need to surgically open up. If it is a vascular malformation or if it is a central hemangioma, you will end up in trouble. Sometimes you might even lose the patient if you are not aware of these things. So, because of this, my own personal experience, I re-emphasize and tell everyone, aspiration is very important. It's a simple procedure. You can just aspirate. You see whether you're getting blood, you're getting a clear fluid, or you don't get anything. It might just tell you a clue or give you a clue as to whether you're dealing with a cyst, or it can be a tumor or a solid lesion, or it is a hemangioma. If you even get a small tinge of blood, you can ask the patient to go for an angiogram. You can ask them to do a Doppler. You can ask them to do a CT. And then you can think about, make precautions, be ready, and then go ahead with doing a biopsy. That would be the better thing. Very, very important that you aspirate all intra-bony pathosis before you go and touch and do any surgical procedure, including a biopsy.
Right. On this, I think even for the diagnosis itself, I know on the oral pathology side, we don't really do it much. But if you listen to Dr. Asitwa Mundal, he is the one who does, he has, I think, diagnosed almost all sorts of cases merely on cytology. So, and I think there are two of his lectures even on the channel. One is about, one is for diagnosis of lesions of the tongue, and one is for pediatric tumors. You should watch those. He literally, and basically, he always, I think I would say almost 80% of his cases, he makes a right diagnosis with just cytology first, with aspiration. Yes. So, but we somehow still, we don't really give it that much
Most of
importance.
us hesitate and we don't really do it, ma'am. Generally, oral pathologist, we straight away go with incisional biopsies. But I think we should try doing it
Yeah.
as and when we
And
see that we can get experts' opinion also if we are not comfortable with it.
yes.
So
And
actually, I
even
would
in South Africa, Professor Hilly also, they also regularly do aspirations.
I would like to add here, with that aspirate, you can go ahead and make a smear or you can make a cell block, like what Dr. Asitwa Mondal taught us. So it really helps. Cell block, you can diagnose most of the our odontogenic lesions. You can differentiate by OKC from say amyloblastoma. You can differentiate. So I feel intraosseous lesion, as Dr. Jayanthi mentioned, aspiration is one of the important aspects which we should all inculcate in our uh,
Right.
pathology. Yeah.
Yes. I think our last question is already answered. Dr. Rebecca is asking, is it possible to differentiate mesenchymal cells from one another in the aspirate? Yes, if you have the right expertise, it is. It is, yes.
Yeah, that is more important.
Yes, the expertise. But I think you need to have the expertise for anything before you can do it. So, yeah, okay. So we have come to the end. There have been, of course, many who say, Professor Joss says it was a great session, and Dr. Priyanka says it's a great session. Dr. Alwan says great session. Thank you all. Dr. Varun. Hi, Dr. Varun. After a long time. No, okay, last time you were there. And okay, so, and of course, we have a lot of our regulars, and they have all watched. And with that, so Dr. Selvi, you need to wrap up with something, with some
Yeah.
comments. So, okay.
So thank you, Dr. Jayanthi, for a varied case presentation, not so common, occurring in the JAWS. And each of the case was very well presented with clinical features, radiographic features, as well as histopathologic features, leading to final diagnosis. I like the part that you gave takeaway messages from each and every case. Like from the case one, you gave that aspiration of intraosseous lesion is very important. And I would like to add to that case that you can do cytosmear, or you can even centrifuge the aspirate content and make a cell block and process it in the same way as we do our tissues, and make sections and see it under microscope. That is one. Another thing what I'd like to add in your case one was that most you mentioned about major criteria and minor criteria, but recently WHO has come out with some all the criterias, like some criterias which have to be present, some in all the cases, some which are present, and there are some additional features. So if out of 10, there are 10 features actually, and out of that, if 7 features are present, then you can give it as a glandular odontogenic cyst, because you have to differentiate it, especially if it is a small lesion, you have to differentiate it from, say, lateral periodontal cyst or maybe botrytis cyst. So that I found it, that I would like to add it. So apart from that, I found your other takeaway messages, like making serial sections is very important, because you never know where you will see an additional feature which will help you in your diagnosis. And you have also reiterated the need for special stain, as well as wherever necessary to go further and do the IHC to help in the final diagnosis. So, and the last case you mentioned in fact about a radiological feature which is seen in case of osteosarcoma, which you saw in your case. But when histopathology was done, it turned out to be a blue cell, round or blue cell tumor, and turned out to be lymphoma, non-Hodgkin's lymphoma of oral cavities. So yes, this is an important message from your side, that don't go only by clinical features and radiological features. The final diagnosis depends upon the histopathology, and in this case, further subtyping needs to be done by using the IHC. So, to conclude, it was a very good, interesting case presentation, especially of the jaw bones and also the not so common. And so, I would like to thank you for taking so much time to collate all your clinical features, radiographic features, and taking your time to come and make this presentation. Thank you, Dr. Jayanthi. And I would like to thank Dr. Mandana for inviting me as a guest speaker out here. Thank you, Dr. Mandana.
You are both very, very welcome. And let me just, yes. So thank you, Dr. Jayanti. That was a very, very lovely presentation, very informative and in depth. And yes, I know I made you cut it short. So you can always come back and present the rest in another subsequent lecture. That will be better. And yeah, it was definitely great. Thank you so much.
Thank you, ma'am. Thank you so much.
Dear Selvi, thank you so much for coming back. It's always great to have you with us. And of course, it's great fun. It's just fun. It's a good chance to, get to see you and to interact with you. Thank you for coming over for this. Thank you. Also, in the beginning, normally I would get a chance to say hi to everybody. Today we got involved. So let me say, everyone I did see, we had, of course, a lot of our regulars. Hi, Dr. Nasser. We had Nandini. Hi. We also had some new people, I guess. Dr. Mudassir from Nigeria. Very nice to have you. Dr. Priyanka, of course, Professor Hill, we spoke with. Dr. Raghu. Hi. And Dr. Elisa Mayondi. She was there last time too, and Dr. Naik, Dr. Parinita, the Rebecca, the Alwan, yes, Dr. Afrin. And we have had also a number of people on Facebook, Dr. Ajay, Dr. Himani, Dr. Sangita, Pallavi, Afrin, Dr. Ashim. Oh, hi, Ashim. And Dr. Suresh, Dr. Manish, Dr. Yogi, Dr. Leena, hi, and Dr. Nikita. And with that, I shall say bye bye. And yes, we shall move on to the next time where it will be great to have you again with us coming Tuesday. Don't forget. Also, get your cases ready for the International Case Presentation Conference. And we hope to see you soon. Bye bye. Have fun. Bye. Bye.